In our second video, we are going to discuss the various etiologies of community-acquired pneumonia and its clinical presentation. There has been considerable debate about the frequency with which different pathogens cause community-acquired pneumonia. Earlier studies often failed to identify a pathogen. However, with the use of respiratory PCR panels, an etiology has been identified in over 80% of cases, as opposed to earlier studies where the cause was determined in only 50% of cases. Bacteria are identified in 80% of CAP cases. Here is a sketch note depicting sputum gram stains of the most common bacterial etiologies. The two most common bacterial pathogens are Haemophilus influenzae, a gram-negative pleomorphic coccobacilli form, and Streptococcus pneumoniae, gram-positive diplococci. Less common causes are Moraxellus catarrhalis, a gram-negative coccus, and E. coli and Klebsiella, both gram-negative bacilli. Staph aureus, gram-positive cocci in clusters and tetrads. When it comes to viral pathogens, they are identified in 30% of CAP. The relatively small, 30 nanometer in diameter RNA virus, rhinovirus, is most common, followed by the larger 80 to 120 nanometer RNA viruses, influenza, and coronavirus. Next in frequency is the larger 120 to 200 nanometer RNA parainfluenza virus. Less commonly, the DNA adenovirus, 80 to 100 nanometers, and the large 150 to 200 nanometer respiratory syncytial virus, an RNA virus, is identified. This table is from a comprehensive clinical infectious disease study that determined the percentages of bacterial and viral pathogens in CAP. The sum of the percentages of bacterial and viral pathogens is over 100% because 10% of cases were caused by dual infections with bacteria and viruses. One of the most common and feared dual infections is influenza superinfection with Staph aureus. This combined infection can be seen during the influenza epidemics and can be fatal. Now let's review a case of community-acquired pneumonia. A 66-year-old barrel-chested retired insurance salesman comes to your office with the chief complaint of he's too short of breath to talk. Present illness: 5 days ago, he developed a fever, generalized muscle aches, headache, and a mildly severe non-productive cough. 3 days ago, he explained a fever that had increased and that his cough had become more severe. Today, the cough is persistent with minimal sputum production, and he denies chest pain. Although the patient is short of breath, he lights up a cigarette. His wife reports that he has been smoking a pack of cigarettes a day all of his adult life. Epidemiology: it's November. There's no influenza in the town that is known. He was an avid hunter, but has stayed home recently. He has known sick contacts. They had no pets, and he has not received his influenza or pneumococcal vaccine. On physical exam, his blood pressure is 110/70, pulse 110, respiratory rate 30, and labored, and temperature is 104 degrees Fahrenheit, and his O2 saturation is 85%. He appears cyanotic, neck veins are distended, lungs moist, crepant rowels heard posteriorly below both scapula. His heart, no murmurs. Neurologic exam, no focal deficits, and he is alert and oriented. To effectively evaluate this patient and enhance diagnostic pattern recognition, many clinicians strongly recommend you summarize the case in an illness script. This consists of a 2 to 3 sentence summary that includes 4 elements. First, pace of illness. Is it acute, 24 to 48 hours in onset, subacute, 3 to 10 days, or chronic, 3 weeks or longer? What are the prominent symptoms? This should be specific. Symptoms like fatigue and generalized weakness aren't usually very helpful. Third, epidemiology. Where do they work? Have they traveled? Have there been any animal or environmental exposures? Have they been around anyone who is sick? What season of the year did they contract the infection? Finally, past medical history. This is usually the least helpful. However, chronic illnesses that may increase the risk of infection should be included. Beware of unusual diagnoses if you do not have the primary data to support them. We are a referral center, and often patients are admitted with inaccurate diagnoses. You should interpret the present illness and use medical terms for shorthand, such as anorexia, myalgias, dyspnea, dyspnea exertion, etc. Creating these carefully organized summaries encourages effective pattern recognition. As emphasized on this sketch note, summarizing an illness script for CAP, epidemiology should include sick contacts, season, travel, other exposures such as time in a small closed public spaces, and finally, vaccinations received should be included. The pace of illness will be either acute or subacute. The key specific symptoms for CAP are cough, shortness of breath, and chest pain. First, cough. Was it productive or non-productive? If productive, what was the color and consistency of the sputum? Rust-colored is associated with strep pneumoniae. Thick mucoid sputum is seen in Klebsiella pneumoniae caused by the thick capsule. Green sputum, due to myeloperoxidase release from PMNs, is seen in H. influenzae and Pseudomonas aeruginosa. Yellow or green purulent sputum is seen in Staph aureus. Foul-smelling sputum indicates anaerobes from the mouth flora and is commonly associated with aspiration pneumonia. Non-productive cough suggests viral pneumonia or pneumonia caused by atypical bacterial pathogens, Mycoplasma pneumoniae, Chlamydia pneumoniae, or Legionella pneumophila. The second key symptom for CAP is shortness of breath. Whenever a patient reports shortness of breath, physicians worry because these patients could progress to requiring mechanical ventilation. Our patient's high respiratory rate of 30 breaths per minute and low oxygen saturation of 85% indicate profound hypoxia. We begin to worry when the saturation drops below 94%. Reduced oxygen levels are the result of fluid in the alveoli preventing the entry of oxygen, i.e., no ventilation. With continued arterial flow, but without receiving oxygen, results in a right to left shunt. It is as though these vessels bypass the lung, thus the name right unoxygenated venous blood to left oxygenated arterial system shunt. The third key symptom is pleuritic chest pain. Patients complain that it hurts when I take a deep breath. This complaint indicates infection has spread to the periphery of the lung with involvement of the pleura. The lungs have no pain-sensing nerves, while the pleura has an extensive pain fiber network. On physical exam, you are likely to find changes consistent with a pleural effusion, that is, decreased breath sounds in the lower lung field associated with dullness to percussion. Rarely you may detect a pleural rub. Review of the literature reveals only a few other common findings in community-acquired pneumonia. Fever is generally present. In patients who develop bacteremia, the patient may complain of rigors, that is, bed-shaking chills. Finally, in the elderly, pneumonia can result in changes in mental status. The rise in cytokines accompanied by hypoxia can result in cognitive impairment. Let's again review our case of CAP. Our patient had the key symptoms of non-productive cough and shortness of breath. He did not have chest pain. He also complained of and was documented to have fever. Having now determined his key symptoms, we can create his illness script. A 66-year-old man presents with subacute onset of shortness of breath, dyspnea, at rest, accompanied by fever, myalgias, headache, and a non-productive cough. He denies chest pain. He has marked tachypnea, respiratory rate 30, sinus tachycardia, low oxygen saturation, and rouse at both posterior lower lung fields. Epidemiology It is late fall. He has no known sick contacts and no animal or environment exposures. He did not receive the flu or pneumonia vaccines. Past medical history reveals he is a 40-pack year smoker and may have COPD. Now that we have created his illness script, we can begin our diagnostic workup, which will be described in the next video. To summarize this video, we listed the most common bacterial and viral pathogen causing CAP. Bacteria are found in 80% of cases, and strep pneumoniae and Haemophilus influenzae are most common. Viruses are found in 30% of cases, and rhinovirus, influenza, and coronavirus are most common. We reviewed the 3 key symptoms of CAP: cough, productive or non-productive; shortness of breath, reflecting alveolar right to left shunt; chest pain, pleuritic, reflecting spread of infection to the peripheral pleura; and finally, we emphasized the importance of creating an illness script to enhance pattern recognition to allow more accurate diagnosis. Thank you.